Welcome to the webinar on management and treatment options for lower extremity ulcers. Today's webinar is presented by WoundRounds, and our faculty member is Laura Patton. If you're a nurse, this session is also available for continuing education units if you're listening live on November 13th. WoundRounds offers a series of educational webinars around the topics of wound care. You can sign up to be notified of future webinars, and you can also go to our archives and watch prior recorded webinars. Please do so at woundrounds.com and go to the Learn page. It's important to note that this particular webinar is a follow-on that we've been building up to in previous webinars. So you might need to go to the WoundRounds webinar page and look at the prerequisite to this webinar, which was entitled Differentiating Lower Extremity Wounds, because the understanding the pathophysiology of wounds is an important prerequisite to what Laura will be presenting today. Additionally, there's also a webinar on dressing for success that is also a useful webinar adjunctive to today's content as well. Both these webinars are available at woundrounds.com. I'd like to next introduce you to our speaker. Our speaker is Laura Patton. Laura is a certified wound care nurse, and she is the implementation specialist for WoundRounds. We're thrilled to have Laura with us today, and she brings with her a wealth of experience that she's gained from prior work in both clinical settings, but also in commercial settings as well. So we're very lucky to have her with us today. A word about me. My name is Deborah Kurtz, and I'm a consultant in the wound care industry and also in the long-term care space. With that, we'd like to kick the webinar off formally by reviewing our objectives for today, and I'll ask Laura to formally get this webinar started. Thanks much, Laura.
Thank you, Deb. To begin, let's go over our objectives for the presentation today. We're going to review the characteristics of venous, arterial, and neuropathic diabetic foot ulcers, identify management objectives and common treatment options for venous, arterial, and diabetic foot ulcers, learn about functional properties of the recommended wound product categories, and explore effective strategies to prevent and manage lower extremity ulcers. Lower extremity ulcers, how big is the problem? The prevalence of leg ulcerations is approximately 1 to 2%. Venous ulcers are the most common form of leg ulcers. They account for about 80% of all lower extremity ulcerations, followed by our arterial ulcers. About 10 to 20% of the patients have arterial components, and ulcers that are caused by diabetes or patients that have diabetes, or 15% of them will get diabetic ulcers. So, problem's huge. Leg and foot ulcerations have many causes that further define their character. Today we're going to focus on the most common causes of ulceration. First, what are the features of those lower extremity ulcers we see most often? Figuring out the type or the etiology of the ulcer you're looking at requires looking at multiple factors. Your physical assessment, looking at the characteristics of the ulcer itself, and vascular and neurological assessment. As far as the ulcer, we look at the different features of the ulcers, diabetic, venous, and arterial. Think about the location. Where do you see them on the patient? What does the patient look like? What are the characteristics of the ulcer? What are some of the features that make you choose one type of ulcer over another? So typically, we look at venous leg ulcers. The leg may be edematous, crusty, weepy. There may be brown hemosiderin deposits. They can tend to occur over the lower 1/3 of the leg, typically shallow, maybe dark red, ruby. They may have some venous congestion. Newer wounds would be higher exuding related to the edema. Peri-wound may be macerated, it becomes waterlogged, and your ABI would be normal. Why do people get venous insufficiency? This is a review from prior webinars. It's the underlying problem for these venous ulcers, the obstruction of the deep or the superficial system or the valves being incompetent. This is a review of the patients that are at risk, other reasons that contribute to chronic venous insufficiency. Review symptoms. You need to remember that chronic venous insufficiency is caused by the long-term blood pressure that's higher than normal inside your leg veins. The fluid builds up in the lower legs, they swell, they can stretch the skin like an oversized balloon. More evident, or your signs going to be more evident, and these are what are associated with that chronic venous insufficiency. And it's really going to be helpful in helping you make that differential diagnosis. Since managing venous insufficiency requires compression, we're going to have to do sensation and perfusion and check about sensation for that patient. You're going to want to look at these differentiating factors that will let you know whether you can manage that venous insufficiency with compression. You want to look at your apical brachial index, see that your presence are palpable, although possibly with edema you may not be able to palpate them, but your capillary pulse should be normal. Venous filling time. Additional diagnostic tests that the doctor can also order to help to pinpoint the source of the problem. Some of those are listed. One of the early signs of insufficiency is venous stasis dermatitis. It's an inflammatory condition caused by chronic venous insufficiency. It'll be erythema on the legs. They may be inflamed. There may be tender vesicles, crusting lesions. Patient will be afebrile. They may be itchy. Could be on one or both legs. They'll have normal white blood cells. The treatment is to treat the underlying cause, which is your venous insufficiency, using compression and some topical steroids to help calm that skin down. This is one of the most often misdiagnosed etiologies versus cellulitis, where cellulitis, the patient may be febrile, they'll be painful, inflamed. There won't be crusting, maybe a few bullae, but it's usually with cellulitis you'll have elevated white blood cells. Usually it's going to be unilateral as opposed to bilateral on the venous stasis dermatitis. Typical location for your venous leg ulcers is going to be the medial malleolus, so your sock or your gaiter area, but they can appear anywhere on the lower leg. Could be the back of the leg, could be circumferential. They're usually large, shallow. They can have a viable, dark red, granular, or necrotic base, generally irregular edges. Most of the time painless, but there may be pain that can occur if it's in a dependent position. The core acronym is a really good way to remember all of the steps that you need to do in order to manage your venous disease and take care of your venous ulcer. The fundamental principles of using CORE, C being compression first, because we know we need to control our edema, and we need to improve that venous return. Optimize your wound environment for O, so we're living in necrotic tissue and maintaining your optimal moisture levels of protection. And review your contributing factors, as well as establishing a maintenance plan. So cover maintaining and preventing reoccurrence. Control the underlying condition, compression therapy, your bandages and the boots and elastic stockings. It remains the gold standard of most treatment protocols for venous leg ulcers and venous insufficiency without concurrent arterial disease. It supports the leg by decreasing the superficial venous and improving your venous return. Compression dressings and bandages provide compression, not so much in the bandages and dressings themselves, but they create a firm barrier where the calf muscles, when they're up against them during ambulation, it supports that calf pump action. So ideally, the compression should be accompanied by leg elevation. You should raise your legs above the heart 30 minutes, 4 times a day to relieve that edema, to help push it out, but it's not always practical. And 3 different types. We've got our elastic compression wraps, not elastic, and our venous pumps. People that just have venous insufficiency need to wear compression hose to help maintain the circulation and prevent lower leg venous ulcers from reoccurring or occurring if they haven't had one. And you select your compression method based on assessment of the patient. So you need to look at their vascular status, level of sedation. Are they able to ambulate, whether there's an infection. You do not apply venous compression if your ABI or apical brachial index is less than 0.9. 0.5, you need to refer to vascular for testing and a surgical eval. And you use compression at 30 to 40 millimeters of mercury at the ankle if your ankle brachial index is greater than 0.8. Your compression bandages can be several layers, with padding, elastic, cohesive layers. The elastic wraps are using stretch and return, so it creates the compression with a stretch and return. Your multi-layer compression wraps are more effective than single layers. Initial treatment of choice for edema and exudate is going to be your multi-layer system. It's great for ambulating and non-ambulating patients. You usually change them 1 to 2 times a week. Depends on the underlying wound and peri-wound conditions. Needs to be applied by trained personnel and changed based on your drainage and your bandage integrity. Generally, there's like a non-stick layer in a lot of them that you put next to the skin, and then there's padding and the compression material. You can use other wound products. You just need to see the manufacturer insert for the products as well as for your wrap. It'll give you a high working pressure, a low resting pressure. It's good for ambulatory and non-ambulatory patients. It'll help control heavier exudate. It's comfortable. Other compression socks and wraps will lose their elasticity over time. TED hose, as a note, only exert 8 to 10 millimeters of mercury at the ankle. That's not adequate for treatment of venous insufficiency. And your anti-embolism is only 15 to 17 millimeters of mercury. Other low compression bandages or elastic or ACE bandages aren't effective on your ambulatory patients for venous insufficiency. Inelastic bandage or your special gauze bandages that are impregnated with zinc oxide and calamine or Una or your Una's boat. It's inelastic and it requires ambulation to engage that calf muscle at the pump. So it gives you a rigid compression, so a high level of compression when the patient's walking. With one wrap of Coband, the compression wrap will give you 30 millimeters of mercury. With 2 wraps, it'll give you 40 millimeters of mercury. But it can't accommodate any changing volume of the leg that might change once you've initially put the compression on. That edema can fluctuate, and it cannot move with it like your compression wrap can with your elastic would, as opposed to inelastic. And again, it doesn't really do anything for you when your patient's inactive. You can do better when you have a multi-layer elastic wrap. And it can't absorb large quantities of exudate. Pneumatic compressions, they've been used for treatment of lymphedema and venous ulceration. Not widely, it's just the first option. The devices are very helpful in patients that have severe edema, morbid obesity, severely impaired movement, or if they have wasting of their calf muscle. There's other options. This would be if these other options are limited. The devices have a bunch of different cups. There's several cups that are filled with air, and they're dynamic, and they sequentially inflate. So they'll be from the toe to the thigh, and they will inflate, and when the first one starts to uninflate, the next one will inflate. And they'll actually kind of act like a calf pump, pushing it out and up, trying to get that edema out. Contraindicated for an active DVT or heart failure. In a Cochrane review, using the intermittent pump for patients who are immobile or need higher levels of compression that they can't get from stockings or wraps can be very beneficial. The thing is, the reimbursement may be an issue because it's not generally reimbursed as a first choice for compression. It's really until other alternatives have been unsuccessful or unless they have a letter of medical necessity. And before you compress, you have to assess. Pressure damage because of inappropriate application of compression bandages can actually be very devastating. You need to go through your arterial assessment and make sure that you have good circulation before you use compression therapy. You need to exclude arterial disease. Because I need to compress that lower extremity, I don't want to cut off circulation and cause any problems. This patient had diminished pulses after they looked at it, so he had arterial insufficiency, and he had severe problems with it, but when they wrapped it, you can see where they actually wrapped the dressing and the marks that were left. Cochrane reviews. Cochrane reviews are unique because they're produced by healthcare professionals, and they're relevant to everyone who's interested in healthcare. It's based on the best available evidence. They aggregate everything, and they can put it all together and put together a benchmark, and it's recognized as a benchmark for high quality and for the effectiveness of healthcare. So they take all of that data out there that all of the vendors are doing and your clinicians are doing, trying to put everything together as far as treatments, protocols, interventions, and they try and tell you what has the best evidence and the best way to be effective in care. And they looked at compression therapy. They found compression therapy heals more venous ulcers and decreases healing time compared to no compression. High compression to treat patients with lower extremity venous disease is found to be more effective than low compression. No difference in the effectiveness of the types of products available for high compression. However, some suggestion that elastic bandages may be more beneficial, and consider a multi-layer system for the elastic layer because it appears to be more beneficial. And is a trial of modified reduced compression bandaging, 23 to 30 millimeters of mercury at the ankle for individuals who may have a mixed arterial venous component, moderate insufficiency, where your ABI is between 0.5 and 0.8 if they present with ulcers and edema. In addition to the use of compression in your core acronym, O would be optimizing your wound environment. So we need to make the wound environment conducive to healing, remove any devitalized tissue, cleanse the wound, maintain a moist wound bed, get rid of any excessive drainage, and protect it. And one more thing, that Cochrane Reviews went ahead and looked at dressings for healing these leg ulcers. And there's a lot of different kinds of dressings used for the treatment of these ulcers, but usually they are beneath compression bandages, but there's no evidence of any additional benefit associated with wound dressings other than simple dressings when they're used beneath compression. No evidence of a difference in healing rates between other dressings, but a lot of the studies were a little bit too small to really rule out some of the important differences. So the recommendation based on what they do have is inexpensive, simple, non-adherent dressing should be beneath a compression dressing. You have to look at what's available to you and your patient preference. If you've got necrotic tissue, the necrotic tissue needs to be removed. Why? Because it's non-viable. You need to clean it up. You need to see what's underneath it. We need to reduce the potential for infection. We need to move it out of the inflammatory into the proliferatory phase. So we get rid of all our slough, yellow, black, brown, anything that's dry and hard. How are we going to do it? Several ways we can do it. Autolytic debridement, because it uses the wound's own fluid to break down the tissue. It softens it up. Use dressings that donate moisture, semi-occlusive or occlusive dressings. There's different sorts of gel formulations or sheets that'll help break it down. It's less painful. You have to be careful, though. You need to protect the surrounding skin from the wound becoming macerated. You need to use that, the autolytic debridement with caution with diabetic wounds or wounds that are affected by arterial insufficiency. Mechanical, use less often. Wet to dry. It can be painful. It's not specific. As you're ripping off the necrotic tissue and pulling it off, you're also pulling off some of the good tissue. You can't separate the two. And you have to do it frequently. Requires frequent dressing changes. Sharp and surgical debridement, fastest way to a clean wound bed. It will trim away the necrotic tissue using sterile scissors. It can be done bedside. Very effective to jumpstart the wound. The thing is, if you want to look at pain management when you're doing any of these debridement, but sharp debridement, you want to consider maybe some topical analgesics for a painful wound. Maybe put some Emla cream for venous ulcer relief when you're doing this debridement so that they can tolerate and you can get that wound cleaned up. You can use chemical enzymes, your collagenate, which will digest those collagen bonds and help you pop off that necrosis that's on the top and release it from the wound bed. And maggot therapy. So sterile maggots, they can go in there and they can also break those bonds and digest some of that necrotic tissue, but it's really, you got to find out if the patient's suitable and if they are willing and able to have the maggot therapy and have these on their wounds. So that's always an issue with that, as well as whatever your care setting is. Hydroductive Debridement I've seen at the force where the fluid is transferred into this hydroconductive dressing very quickly, so it can actually cleave some of that collagen and bind some of the collagen that binds the necrotic tissue into the wound. That's something that's available and out there. Not a lot of data that I've seen on it, but it's another option. You got to look at the wound when you're doing your assessment and look for your signs of infection, any inflammation. Remember, you've got an open wound, you've lost your protective barrier, so your topical antimicrobial or antibiotics can be prescribed to clear skin infections that are related to your chronic venous insufficiency, but you still have to treat the underlying disease. You want to prevent reoccurrence. Deeper tissue infections, your cellulitis, you need to have systemic treatments. Guide your antibiotic therapy using cultures. You need to avoid any known skin irritants or allergens in patients that have dermatitis or eczema. A lot of times there is some of the antimicrobials they do have allergic reactions to. Multi-layer wraps help to manage some of the moisture, but depending on the wound base, drainage, you're going to need to select a dressing. So we need to select a dressing and manage our peri-wound area. Peri-wound, we can moisturize and protect, use emollients, petrolatum to manage any dry, scaly skin. If you have moist, denuded skin, you may want to put wound veil. If you can't, put a wound veil covering an alginate to help get rid of some of that additional edema underneath your wrap. Dry, denuded skin with some Duraform on it. Any reddened skin, you could look at a moderate strength steroid. Skin surrounding that wound causes more problems than the wound itself if you actually have the wound dressing that doesn't absorb enough exudate. You end up with an eczema inflammation because that toxin that's released from the hypertensive veins into the lower leg. One of the main goals of the wound management is to provide appropriate moist environment for the healing that will prevent the cells from dying. So the foam, in various shapes and sizes, polyurethane, sized with small openings. And they have the ability to pull away the exudate from the wound bed with various forms of specifics for fluid handling. Generally absorbent and don't lint, which is great. Single layer, some are thicker, multiple layers related to the absorbency, good for moderate to heavy exuding. Therefore, if you have the absorptive ability of the foam is really important because you have to match the amount of exudate that you're having. If it's labeled light or thin, it may not absorb as much as you need it to based on what's going on with your wound. Extra or plus may be great, but it may be too much. Because remember, you need to think under compression wraps. You want to avoid putting too much bulk, so you want to have something that's kind of a low profile. If we have too much bulk, you can decrease any sub-bandage pressure because you're going to be increasing your limb size. Next thing you know, you have an increased amount of exudate pouring out, so now you have poor edema control. So you think under compression, so you want to absorb the exudate and protect the surrounding skin and choose the correct dressing that'll match that. A high absorbency rate might be great. Oh, I have too much exudate. Go high absorbency, but you need to look at what is your frequency between dressing changes and when are you going to change those wraps, because if it stays on longer and you absorb too much, now it may be left in place 3 or 4 days, and you can have a foam dressing that sticks to the wound bed related to, you've got trauma and pain trying to pull that off. Now, some of the dressings will come with a non-adhesive layer that will allow for an easy removal from the wound as well. One of the other things is you want one that's going to be easy to fit into the cavity and cut it to the size of the cavity, and before you put it in, bevel the edges because they work really well, but the edges tend to butt up against the sides of the wound, and now you're causing more damage to the edge of the wound by having the edges kind of butt up against it. So if you can kind of taper it once you've cut it, it'll work really nice for you. Because they're moist wound healing, they can also promote autolytic debridement. So they can also help inhibit the formation of any hypergranulation tissue. So foams will work in that way. The foams aren't working, you have more exudate than that, and you're not changing your dressings. You may want to look at an alginate or one of the higher absorptives. Your alginates, your hydrofiber, they're very conformable, flexible. When they come in contact with the exudate, they'll form kind of a protective gel. Some of them will actually swell, some of them will dissolve, depending on what's in them. They uniformly will absorb the exudate, which kind of protects the peri-wound area, and it'll help maintain that moist wound environment. What you want is one that you're going to be able to pull out in one piece, because if it stays in the wound, then you're going to have to consistently irrigate and trying to clean it out. You can cause pain to the patient and damage to the new tissue. You want to make sure that when you're placing it in there, you have one that's not going to be too viscous, because if you fill your cavity with something that turns to a gel and your patient is walking around, if with the body temperature it tends to slide, gravity will pull on it, it may not stay in your wound. Now you have a gel that's sliding down the dependent part of the wound, and now your peri-wound can be macerated. So you want to protect your peri-wound area, obviously, but maybe choosing a different hydrofiber or alginate or one of the fiber absorptives may be doing the trick as well for you, as opposed to having to put layers and layers of thicker barriers around the outside of already fragile skin. Some of the quick-wicking products also may help move the exudate quickly away from the wound. It is a primary dressing, so you're going to need to keep it in place with a secondary dressing. And these will come, these absorptives will come in wafer sheets, roped, so they're very easy to fit to the size that you need. Provide a moist wound healing environment, so they do work well as well to promote autolytic debridement. Your hydrocolloids are for a small amount of exudate, minimal to moderately absorptive, do well to facilitate autolytic debridement. They work well underneath compression wraps or stockings as a secondary dressing, or to prevent areas of high risk and friction, but you need to consider it. It's great for pain for your lower extremity venous ulcers, but you need to consider when you're going to do the dressing changes. Some of the dressings can adhere to the wound bed and make it really difficult to remove, depending on how long they're designed to stay in place with their adhesives. They can cause an odor that people might think is an infection. You may leave residue in the wound, and again, now you're irrigating the wound and you're damaging the wound trying to get part of that product out. So you want to take a look at that. And they're kind of, needs to be ready to be removed based on the adhesive, and make sure that it contains the drainage underneath your compression. Hydrogel is water or glycerin-based, non-adherent, and they can absorb a little bit of exudate, but mostly they're going to donate moisture. They come in sheets, tubes, and powders. They rehydrate that wound bed. Great to reduce pain. You can use them with other topical medications, and they're great for promoting autolytic debridement. Not adherent, easy to remove, but they generally need to be changed daily, so you need to look at this. If you're going to use this under a wrapper, you're going to be unwrapping that patient's wraps every single day, so that you can put more of a hydrogel on there. And generally, they're going to be used if a patient has a dry wound or for autolytic debridement, not for a moderate heavy draining wound. Finally, you have this chronic wound. You need to make sure that you review the local and systemic factors that contribute to this impaired healing. You want to make sure that this wound is progressing. You want to look locally, and if they have venous disease, they may be prone to developing allergies to neomycin, lanolin, or parabens. You want to look at the local tissue to see if it's hypoxis related to the edema not being managed well. Look to see whether there's infection. Make sure the wound bed isn't dehydrated or desiccating. It's important to remember, all the systemic factors that also go into stalling that wound and keeping it from healing. One of the things, remember, the most beneficial thing they can do is get them out and see if you can get them walking to get that calf action pump going so they can get that venous return. So in addition to the interventions, there may be some medical interventions and surgical interventions. Surgical correction alone won't significantly increase the rates of healing for venous leg ulcers. However, surgical correction of your venous reflux with compression can reduce the reoccurrence of the venous leg ulcer. So it might give them a greater amount of time that the patient would be ulcer-free. If you don't see healing in 30 days, there are recommendations that you look at some of these adjunctive therapies, some of your skin substitutes, your split-thickness skin grafts, but now you're doing another surgery. You might want to look at HBO. They don't have a lot of data on HBO and venous leg ulcers, but they have looked at significant reduction in one study that was noted by Cochrane in conjunction with HBO and compression. So establishing a maintenance plan to prevent reoccurrence. The reoccurrence rate of venous leg ulcers is 70% following having a without using your long-term compression therapy. So it's going to be really important to follow up on patient education. You need to start early in the treatment, start educating them about their role in caring for the wound and caring for the edema that they have. One of the reasons that they find that they reoccur if the patient is non-compliant is because they really don't know about the disease, the process, and why do I have to wrap my leg? So, lack of knowledge. It's important to make sure that, wound closure is achieved through using that compression therapy. Best treatment is going to be prevention, so make sure they know they're going to wear compression stockings forever. Graduated compression stockings, once that edema is under control, patient's going to be using their own stockings. They need to be taught that they should have 2 pairs. They need to wash them by hand. One can be drying. They need to wash it daily. One can be drying while the other one is being used. They should replace them about every 6 months because those fibers are going to wear out. There's no longer applying the compression. They need to be measured early in the morning, generally before they get out of bed, so you can appropriately fit them, and they should be remeasured in about 6 months to make sure that same size is fitting them. Take them off at night before they go to bed and put them on before they get out. Now, if they get up and they need to get their cup of coffee before they put them on, they should maybe take their cup of coffee and go put their legs up for 20, 30 minutes before they put their stockings back on. They need to make sure there aren't any wrinkles when they're putting them on. And start at the base of the toes and pull them up and make it easy for them. Try and use plastic gloves, moisturize your legs before applications, use powders. Tell the patients not to fold and remove wrinkles. You just want to extend the lifespan of the stockings and make sure the patient is comfortable trying to put them on. If there are issues related to their age and their dexterity and they just can't get them on, there are devices that patients can get to help them apply them. The only caveat is Medicare reimbursement is a hurdle right now because you have to have a prescription of 30 to 40 millimeters of mercury, and you have to have an active ulcer. So you might get a pair covered on your way out of the hospital or with your active ulcer, but once your ulcer is healed, the patient's going to be hit for $70 to $90 for each one of these. So I haven't read Obamacare, but maybe there's something written in there for this. And as always, patient education about lifestyle changes. They need to be told they need to exercise, improve nutrition, no smoking, and encourage them to undertake physical activity so that they can actually prevent this from happening. Again, here's a summary. Typically, the leg ulcers occur in the lower third of the leg, like edematous, weepy with crusts, brown deposits, your hemosiderin deposits, and they'll be shallow. The peri-wound may have some maceration if it becomes waterlogged, but they're alveoli normal. Moving into arterial ulcers, they're going to be at the distal extremities, small and round with less exudate. Usually going to be dry. They're going to be around the toes, so you're going to feel that the extremity is cool to touch. They're going to be in an area where it's rubbing from footwear. They're going to have a punched out appearance. This is just a review of what causes peripheral arterial disease, atherosclerosis, the hardening of the arteries, and it narrows up, and it's a cascade from there, stopping the circulation. reviewing the symptoms, understanding the biggest complaint you're going to hear, the hallmark sign of peripheral arterial disease, is pain. And the severity of the pain kind of will indicate the severity of the disease. You know, the claudication, the pain is exercise-induced, and so that they can walk two blocks, they get so much pain they have to stop, they rest, they can walk a couple more blocks. And they feel that they're getting into bed and then they're having pain, then you know it's really gone to where we have the nocturnal pain and it's not even exercise-induced, kind of like angina. In the physical assessment signs, you're going to see these characteristic changes. You'll see with arterial wounds, there'll be an absence of hair growth, muscle wasting, thin, pale skin. It'll be taut and shiny. And who gets it? This will list the risks of getting peripheral arterial disease, and it'll be generally higher in patients that are over 50 years old. So assessing the vascular status is going to be really important again. So we need to determine if healing is even possible. There's non-invasive tests that can be done to help you assess the blood flow. You need to check the patient's circulation. Mild peripheral arterial disease is asymptomatic. Moderate to severe, you're going to see these diminished pulses or absent peripheral pulses. So you're going to want to check the capillary refill. You're going to want to check the ABI, and if you can't do an ABI, maybe a TBI should be done. Characteristics, these ischemic ulcers will occur over that distal portion or the tips of the toes, the forefoot, spontaneously at pressure points. Minor trauma will precipitate it. They can also commonly happen in the nail bed. They can go in for an aggressive toenail trimming, or an ingrown toenail will be removed and you can end up with an arterial ulcer. They just don't have the circulation to go in there and heal up that area. So goals need to be made after you've looked at the bigger picture. So does the wound have the vascular supply that it's going to need in order to heal? You need to assess the healing potential for a patient before you figure out whether you're going to be able to do it. You need to have adequate blood flow to heal. So if you've got adequate perfusion, the goal is going to be promote wound healing, prevent trauma, injury, use the dressings that will permit an easy, frequent viewing of the wound, and if you have an infection, treat infection aggressively. So if you've got an open non-necrotic wound, you can consider like a non-occlusive absorbent dressing. If you've got a necrotic one, you can monitor it, maybe closely do a trial of autolytic and enzymatic debridement. If you've got exposed bone in an open draining wound with bone or tendon, maybe you want to monitor a trial of a non-occlusive absorbent dressing, but you're really going to want to monitor signs of infection that can involve, the soft tissues of the bone, because these patients don't have the circulation to heal, and those signs are going to be delayed related to the fact that they do not have the circulation. You've got infected necrotic wounds, you need to refer for revascularization and surgical removal of necrotic tissue and antibiotic therapy. You don't want to rely on any topical antibiotics to treat infected ischemic wounds. One of the things that can help with the pain is using non-adherent type of contact layer, because these are, a lot of times very, very painful. We know they're low draining. You can use that with a secondary dressing and then protect it from trauma. Ischemic ulcers that are covered by Ascar, you need to, again, assess your perfusion status, but if there's no evidence of infection, your goal might be to keep it dry unless the patient can be revascularized. You can usually get something achieved by improving the circulation with a bypass graft or angioplasty, but if you're not able to and you can't debride it, you just need to keep the wound bed dry, protect it, reduce any risk for infection. These wounds are typically very painful, so like a silicone contact clear or a veil would be a good choice as your primary dressing here, if the wound, provided the wound's not infected and we just have a dry wound. If the wound consists of dry gangrene, then you may want to put some betadine painted on it or iodazole painted on it, and you want to place that over the gangrenous tissue. You want to keep the gangrenous tissue dry. There's a high risk for amputation in patients who can't be revascularized, or if that gangrene converts to a wet or a gas gangrene. How the ulcer is prevented, 2 goals are going to be managing the underlying disease and managing the wound. You need to prevent the ulcer from developing or prevent them from getting worse. And some of these are going to be your risk factors, so manage your risk factors, correct your numbers, and manage any diabetes, don't walk barefoot. And again, patient education is extremely important. It's all outlined below. That's arterial ulcers. We're going to talk about our feet, our heels, our tips of the toes, between the toes, where the toes rub, sites of trauma, around the lateral malleolus, and they're small, punched out in appearance, kind of a dry, pale pink, maybe necrotic wound bed, minimal draining, and painful. Diabetic foot ulcers are usually deep, even round margins. Most of the time, they'll be surrounded by a callus around the ulcer in a pressure area. They'll be painless. They'll have granular tissue. Sometimes it's pink. It may be darker if there's a vascular component in there. Often you'll see an osteomyelitis or cellulitis in there. Plantar aspect of the foot is a common place for it, associated with diabetes on your metatarsal heads, your heels, altered pressure points. There's many reasons why diabetic foot ulcers occur, but 3 main reasons are going to be uncontrolled diabetes, it damages the nerves, neuropathy, autonomic and peripheral vascular disease. Some of the signs and the symptoms are going to be an altered gait, paresthesia of the extremities, there's going to be orthotic deformities, and there's going to be pressure points that develop, and those are going to have repeated trauma, and the altered sensation, they're not even going to feel what's going on because of the neuropathy they have. Since neuropathy is associated with diabetes, this is where the wounds result from that damage of that neuropathy, so you want to take a good history. You're going to want to find out the onset of diabetes, their comorbidities, and you're going to have to do a good neurological assessment. And again, you've got to do your vascular assessment. If you can't do an ABI, this is where you're going to do a toe brachial index to try and find out what is going on as far as the patient's vascular system and any circulation issues on top of the diabetes. You want to get a previous history of the wounds, surgeries, any time they were free from wounds, any special treatments that they used, and where they were on the foot. Again, check for sensation, because one of the biggest things they have is that loss of protective sensation, so they can repeatedly cause trauma to the area, and they're not even knowing it. Charcot joint disease is a destructive joint changes that happen in this neuropathic foot. Initially, the patient will be walking around on it, and there's a history of trauma to the foot, and they'll be walking around, it'll be hot and swollen by the time they've gone through, and the bone is breaking down, and the fragmentation occurs. In that last stage, they continue and they walk on it, and now they have like a rocker bottom, and there's a huge amount of pressure at that area. Again, on the tips of your toes, plantar surface of your foot, they're round. They're round especially if there's going to be a callus around the area, because generally if I've got this strange pressure point, I'm going to develop a callus around it. Wound bed's going to be probably granular. It may be a little bit dull. Not a lot of pain, because remember, we've got neuropathy. We've got a foot that can't feel it. You can check this by checking the patient's feet, touch the extremity, look at the bony prominences. It's something that you can just see as you're doing care. You can go in there when you're bathing the patient and take a look at the feet, look at the bottom of the feet, between the toes. Check the temperature of the extremity. Does the skin look dry? Does it look good? Does it feel overly moist? For topical management of your diabetic foot ulcer, you need to avoid the pressure point and weight bearing on that affected area. Regular debridement of any tissue that's necrotic is really necessary, but also on the callus area, you're going to have to make sure that you keep that callus area free and debride that. You're going to need special shoes or orthotic devices to actually offload that area. select topical therapy that's consistent with your goal of care. You're going to protect and prevent infection, so maybe you need an antimicrobial. Remove any contact irritation, so remove what's causing the pressure. Use dressings that will maintain a moist wound surface and absorb exudate and allow you to view easily. Careful with occlusive dressings and aggressively treat infection, even fungal infections. You don't want to rely on any topical antimicrobials to treat cellulitis, so you're going to need to look at systemic antibiotics and make sure you debride any avascular necrotic tissue. Just take special care because now you've opened it up for any antimicrobial, any bugs to get in there, so you're going to want to probably cover it with an antimicrobial dressing. If the wounds aren't responding, you can look at skin equivalents, HBO, negative pressure, growth factors. Another thing about the calluses occur when it builds up faster around that strange area on the joint or on a bony prominence that they keep on walking on it, so it gets really thick and it starts to break down. So you need to have a podiatrist or a professional go in there and trim that and debride that. You want to keep them under control. Good debridement and removal of the callus, because you don't know how deep it is, can actually reduce the pressure at the site because it's pushing down, reduce the pressure at the site by 30% by getting rid of that callus. Pressure relief for heel ulcers, offloading a little bit. You've got specialty boots, surgical sandals, the healing sandal, but offloading is going to be what you're going to need to do to stop that from coming back and to help the one that you have heal. Contact casting, forced compliance. It's great. The physicians love it. The patients not so much. It's really restrictive. They can put it on their patient. They find a product that can work underneath there, and a lot of times it's just moist wound healing and offloading the area that helps heal it. Some of the walking boots, they can go in, they can put that on, but you'll see the patient leave the wound center for it in the back of the car, and it probably sits in the back of the car, and the patient goes back to the wound center. We don't know. Do they put it on after that? But contact casting is an appropriate footwear, as well as any offloading, are going to be key to taking care of this problem. Self-care, patients need to control their diabetes. The risk is decreased if they can control their blood sugars. Wear comfortable, well-fitting shoes. Look at their feet every day. Avoid hot water bottles. Don't walk barefoot. Use socks with your shoes, and always wear shoes. Don't wear open-toed shoes. All of those things that are really going to protect them, because remember, they can't feel it, and the repeated trauma is one of the reasons that this keeps happening. So again, diabetic foot ulcers, they're deeper, painless, around even margins, and a lot of times you'll see that big callus ring around it. Granular tissue, unless they have vascular components, sometimes it'll be a little darker, but associated with diabetes on the plantar aspect of the foot. So, I thank you.
Wow, Laura. That was a great presentation. Thank you for this outstanding content today. We'd also like to thank WoundRounds for sponsoring today's webinar and for making CEUs available for nurses. Thanks, Laura, for putting together a great resource list. So there's 2 slides here with some great follow-up information for you to take back to your facility. And lastly, what we'd like to do now is open up the floor to questions. And for those of you who don't have time to get their questions in now, you can feel free to follow up with Laura. Her contact information is here on the screen. So our first question for Laura is, in our facility we have a patient who's wearing a layered compression wrap. And this wrap is now starting to smell. It's been a couple days since application. We're wondering, Laura, if you have any advice for this facility.
I probably would say we need to take it off and see what's underneath there. If it's just at dressing chains, it smells, then okay. When you go in there, make sure there isn't an infection, first and foremost. If you need an antimicrobial topically, maybe you need to do more frequent dressing changes. Maybe what you're using is not handling it, and if all else fails, you can always take like a charcoal dressing and put that on the outside of the antimicrobial that you're using prior to the compression wrap, so that you can put something that actually will cut down on the smell. But there's got to be a reason it's smelling, so we need to investigate a little further.
Thanks, Laura. We have another question, this one also relating to a venous leg wrap. This facility writes in that they just removed a venous leg wrap and that they found the skin underneath to be all shriveled. Any insights?
Well, if the patient was edematous, it's possible that we have just removed a lot of the edema. So I'd really need to know more, but if we had a lot of edema and originally our skin was stretched out and we pushed out a lot of the edema, a lot of times that's normal. There's going to be wrinkled skin and that it will actually even out. It'll go back out a little bit for you, so that those wrinkles will be out of there. But if it's an initial, getting rid of the edema, that's what it's going to look like. It's okay.
Laura, thank you. And that wraps up our questions for today. We'd like to once again thank Laura for sharing her wisdom with us today, and also to thank WoundRounds for making this webinar available. And for those of you who have signed up for WoundRounds webinars, watch your email for upcoming information about new webinars that are planned. And if you haven't yet joined, please sign up for to be on the WoundRounds mailing list at woundrounds.com. On behalf of WoundRounds, I'm Deb Kurtz, and I want to thank you for participating today. Thanks, and see you again.